They teach you early in critical care nursing that death is an absolute. You learn the signs in your first semester: the fixed pupils, the cooling skin, the silence of a heart that will never beat again. There's a checklist to it, a rhythm that becomes mechanical after enough years. Confirm, record, cover, call. You don't question it. You can't afford to. I've been a nurse for 18 years. My name is Rachel Kerr, and for 16 of those years, I worked in the neurology and critical care unit at St. Matthew's Medical Center in Minneapolis, a hospital known for handling some of the most complex brain and cardiac emergencies in the Midwest. I've seen things that could make most people walk away from medicine forever. But nothing, not the codes, not the traumas, not the quiet deaths at 3 a.m., prepared me for what happened last November. It was the case that ended my ICU career, and it still wakes me up some nights. It started like any other shift. It was November 9th, 2023, a Thursday night, cold, steady rain outside, the kind of gray evening where the whole city seems to move slower. My shift began at 7. By 9, the unit was steady, a few stroke patients, one post-surgical neuro case, and a ventilated trauma transfer from Duluth. My new admission that night was Michael Alden, a 62-year-old retired architect who'd been brought in 2 days prior after a small ischemic stroke. He was stable, recovering well, and due for discharge over the weekend. There was nothing remarkable about his case: mild speech slurring, some weakness in his right hand. His MRI looked clean post-thrombolysis. He wasn't one of the complicated ones. If anything, Michael was a breath of calm in an otherwise heavy week. He was sharp, articulate, the kind of patient who made jokes about hospital food and asked intelligent questions about his medications. He told me he'd spent most of his career designing public buildings in downtown Minneapolis, museums, schools, a few hospitals. He even laughed about the irony of ending up in one of them. His wife, Nora, visited every day, sitting quietly by his bed, knitting scarves while we adjusted IVs and monitored his vitals. They'd been married 40 years, and you could feel the depth of that history in the way she looked at him. Michael, for all his easy humor, kept glancing toward her like he didn't want to miss a single second. 11:14 p.m. The first sign of trouble came late in the night. I was halfway through a medication round when I heard a monitor alarm, a long, steady tone that cut straight through your spine. I looked up at the telemetry board and saw Michael's name flashing. Datch detected. I moved fast. When I reached his room, he was awake, pale, sweating, clutching his chest with one hand. "It feels like my heart's fluttering," he said. "Not painful, just weird." His heart rate was 176, irregular, the waveform a jagged mess of peaks and troughs. I silenced the alarm, grabbed the crash cart, and called out to Dr. Claire Menendez, our attending neurologist that night. She was only 2 doors down and came running. Within seconds, our small team was in motion. EKG, oxygen, 4-access labs. We were trained for this choreography. Dr. Menendez stood at the foot of the bed, calm as ever, eyes scanning the monitor. "Let's get a stat cardiology consult," she said. "He's throwing PVCs on top of VT. We're not waiting for it to self-correct." Cardiology sent Dr. Raj Patel, one of the fellows on call. He arrived in under 5 minutes, record time. By then, Michael was drifting in and out of awareness, his pulse thready, lips pale. "Stay with me, Michael," I said, holding his hand, my other hand checking the radial pulse that kept slipping away under my fingers. We administered medications, adjusted electrolytes, started antiarrhythmic support. His rhythm slowed, steadied, then, miraculously, returned to normal sinus. Everyone exhaled. Dr. Patel looked up at the monitor and said, "He's back. Let's keep him on the drip overnight. We'll do an echo first thing in the morning." For the next 3 hours, Michael rested. His breathing evened out. Nora had gone home hours earlier, and I called her to update her. I told her he'd had a brief episode, but that he was stable now. I didn't tell her how close we'd come. At 3:58 a.m., the alarm sounded again. When I reached the room this time, Michael was unconscious. The waveform on the monitor had degenerated into chaos, ventricular fibrillation. "Code blue, room 214, I shouted, hitting the wall button. Everything blurred into that terrible, organized panic. CPR, defibrillator, adrenaline, compressions, time calls. The room filled with people, Dr. Menendez, Dr. Patel, respiratory therapy, 2 additional nurses. The air smelled like antiseptic and static electricity. We shocked him once, nothing. Twice, still nothing. We continued for 40 minutes. His pupils went fixed. The monitor flatlined. At 4:46 a.m., Dr. Menendez called it. Time of death, 4:46. And, just like that, the noise stopped. The room went still, except for the faint hiss of the oxygen line I hadn't turned off yet. I stood by the bed, staring at the man who'd been joking with me only hours earlier. He looked peaceful, almost asleep. I felt that familiar hollowness settle in, the one every ICU nurse learns to hide behind professionalism. I removed the leads, disconnected the IVs, straightened the sheet. I closed his eyes. Then I went to call Nora. She answered on the second ring, her voice groggy. "Mrs. Alden," I began. "I'm so sorry to tell you this, but Michael." She didn't let me finish. "He's gone, isn't he?" I paused, surprised by how certain she sounded. "Yes," I said quietly. "He passed at 4:46 a.m. We did everything we could." There was silence, then a quiet sob. "I knew it," she whispered. I woke up at 4:45. I just knew. I stayed on the phone with her until she said she was on her way to the hospital. By 5 o'clock, I documented the event, tagged the time of death, and covered Michael's body. I sat at the nurse's station finishing the charting, the exhaustion settling in like lead. That's when I heard it. It was faint at first, a soft beep. Then another. Then another. My head snapped toward the telemetry screen. Michael Alden, bed 214, was showing an active rhythm. I froze. The heart rate read 76. Normal sinus. No artifact, no interference. I blinked, leaned closer. The waveform was clean. That's impossible, I thought. I'd taken the leads off myself. I ran back to his room, my mind racing between logic and dread. When I opened the door, everything looked the same. The sheet pulled over his chest, the silence, the still air, except for one thing. The sheet moved. Just once, gently, like someone taking a breath. My stomach dropped. I pulled it back. Michael's chest was rising and falling, steady, rhythmic. His skin was warm. I pressed 2 fingers to his carotid artery. Pulse. Strong. Regular. I stumbled back and yelled for Dr. Menendez. She was there within seconds, disbelief flashing across her face when she saw the monitor. She checked for herself, pulse, respirations, pupillary reaction. All present. "He's alive," she said softly. We both stood there in silence, staring at a man who had, by every medical definition, been dead for nearly 15 minutes. Where am I? At 5:08 a.m., Michael opened his eyes. He looked around, confused, blinking under the harsh fluorescent lights. "What happened?" he asked, voice hoarse. "Why does my chest hurt?" I couldn't speak. Neither could Dr. Menendez. "You coded," she finally said. "Your heart stopped. We tried everything, but you came back." Michael frowned. "I know," he said simply. That sent chills down my spine. "What do you mean, you know?" I asked. He looked past me, eyes unfocused. "I saw it. All of you. The room, the lights, the people shouting. You were standing on my right, near the bed rail. The doctor was calling times. My throat went dry. He was describing it perfectly, down to my position in the room. He went on, and then everything went quiet. I saw myself from above. I could hear Nora crying, even though she wasn't here yet. And then there was this light, not bright, more like warm." He paused. It was peaceful. I didn't want to leave. But then I heard her voice, Nora's voice, saying my name, asking me not to go. And then I woke up. He said it calmly, without hesitation, like he was describing a dream he was certain was real. Dr. Menendez and I exchanged looks. There were no words for what we were hearing. By sunrise, Michael's vitals were completely normal. We ran every test we could: EKG, blood gases, echo, labs. Not only was there no damage, but his cardiac function was better than it had been the night before. No arrhythmia, no abnormalities, no sign of oxygen deprivation. It didn't make sense. People don't come back from flatline, not after 15 minutes. Word spread fast through the hospital. By noon, administrators, cardiologists, and neurologists had crowded into the unit, reviewing telemetry data, scanning records, replaying code footage. They couldn't find an explanation. They called it spontaneous return of circulation. But that phrase was a placeholder, a way to label something no one actually understood. I went home that morning unable to shake the image of his body breathing under that white sheet. I told myself it had to be some freak electrical glitch or misread, anything other than what it felt like. But when I came back the next night, Michael was sitting up in bed, eating oatmeal and chatting with Nora. He smiled when he saw me. "You were there," he said quietly. "You brought me back." I tried to smile, but it came out wrong. "You brought yourself back," I said. He shook his head. "No, something else did." For the next few days, I went through the motions of my shifts, but something inside me had shifted. I'd always prided myself on composure, the ability to maintain order in the middle of chaos. But after that morning, I couldn't shake the image of Michael's hand twitching under the sheet. It replayed every time I closed my eyes. Hospitals are designed to explain things. We run on data, protocols, and cause and effect. But this had no place in the order of things. I met with Dr. Menendez in the staff lounge later that week. She looked just as tired as I felt. "They're calling it spontaneous circulation," she said, pouring coffee she wouldn't drink. But no one believes that. Not after 15 minutes flatlined. "They think we made a mistake?" I asked. "Some of them do," she admitted quietly. "They're reviewing everything, telemetry, timestamps, even the EKG leads." "But Rachel," she hesitated, then met my eyes. "I know what we saw. He was gone." I nodded, but it didn't help. Knowing didn't fix the dissonance between science and what we had witnessed. Michael stayed in the unit for 5 more days. Every test came back pristine. His heart function was textbook perfect. His brain scans showed no sign of oxygen deprivation. He should have been brain dead after that long without circulation. Instead, he was walking, laughing, and remembering everything. On his last day before discharge, he stopped me in the doorway. "You haven't slept much," he said with a small, knowing smile. I tried to deflect. "Neither have you. Hospitals don't exactly encourage rest." He shook his head. "No, I mean it. You're still thinking about it." Of course I was. I'd been thinking about nothing else. Michael leaned forward, lowering his voice. "I know what I saw sounds impossible, but it wasn't a dream. I was there, above everything. I heard the machine stop. I saw the clock. I saw you cry." That last part hit hard because he was right. In that moment between coding and calling time, I had turned away for a split second, just long enough to blink back tears before anyone noticed. "How could you know that?" I whispered. He smiled sadly. "Maybe we're not supposed to know. Maybe we're supposed to feel it." That was the last thing he said to me before discharge. Word spread fast, too fast. Within a week, hospital administration was calling it anomalous resuscitative return. It sounded clinical, sterile, detached. But underneath the official language was a quiet unease no one wanted to admit out loud. The Quality Review Board launched an internal audit. They wanted data: how long compressions were performed, how much epinephrine was given, what time each event was logged. They even requested to interview every member of the code team. I sat in a conference room across from 3 administrators and 2 physicians. They asked the same questions in different ways, circling the same unspoken accusation. "Did you call time too early?" "No," I said firmly, my palms sweating against the table. "We followed protocol. We verified." He had no pulse, no pressure, no activity. His pupils were fixed. One of them, a man from the legal department, scribbled something down. And yet, 12 minutes later, he resumed spontaneous function. I met his eyes. He came back. He didn't respond. He didn't have to. The silence said enough. When the meeting ended, I felt smaller than I had in years. I walked out of the conference room, past the rows of chairs filled with new interns waiting for orientation, and realized I was one of the oldest nurses still on the unit. And suddenly, I wasn't sure I belonged there anymore. Over the next few months, I tried to continue as usual. I told myself Michael's case was an anomaly, a medical curiosity that would fade with time. But it didn't. Every time a monitor alarmed, I froze. Every time I saw a code, I hesitated, not out of fear, but out of uncertainty. What if we were wrong again? What if death wasn't what we thought it was? I started double-checking vitals long after everyone else had left the room. I'd find myself hovering over still bodies, fingers pressed to cold skin, waiting for something, a twitch, a flutter, a sign that life wasn't done yet. It unnerved my colleagues. Ratch, one of them said gently during a night shift, "You've got to let go. You're making yourself sick." Maybe I was. But once you've seen someone breathe under a death sheet, you can't unsee it. It happened 9 months later. Different patient, different circumstances, but the same haunting feeling. Her name was Ellen Vargas, 74, admitted with a massive subarachnoid hemorrhage. She never regained consciousness after surgery. Her family had made the decision to withdraw care once all neurological testing confirmed brain death. I'd been the one assigned to her final night. When we extubated her and disconnected the monitors, her heart rate slowed predictably, then faded into nothing. I confirmed absence of pulse, respiration, and reflexes. I documented the time, 2:17 a.m. I stood there afterward, staring at her still form, remembering Michael Alden, remembering the impossible. So I waited. 5 minutes. 10. 15. Nothing. And yet, part of me couldn't walk away. I kept one hand on her wrist, the other on the bed rail, my breath matching the ticking of the wall clock. I waited until 2:40 before finally turning to leave. When I glanced back, the heart monitor, still plugged in but inactive, flickered. Just once. A single, faint pulse wave. Then nothing. I nearly dropped the clipboard. I called for the charge nurse to check the leads, pretending it was just static interference. But I knew what I'd seen. That flicker stayed with me. Deeper than fear, it felt like confirmation. By the end of that year, I couldn't keep doing it. Critical care demands certainty, action without hesitation. I didn't have that anymore. Every time I touched a patient, I wondered if they could still feel it from somewhere we couldn't measure. When I handed in my resignation, the nurse manager tried to talk me out of it. "Rachel, you're one of our best. This is just burnout. Take a few weeks off." But it wasn't burnout. It was doubt, the kind that corrodes everything it touches. I transferred to an outpatient neurology clinic. No codes, no ventilators, no overnight alarms. Patients who walked in and walked out on their own. I told myself I'd find peace in the simplicity. But some nights, even now, I still see the telemetry wave in my sleep, the clean, perfect line of normal rhythm that shouldn't have existed. 3 months after I left St. Matthew's, I received an email from Dr. Menendez. Subject: Follow-up, Michael Alden. Rachel. Just wanted to let you know Michael came in for a 6-month checkup. He's doing remarkably well. No arrhythmias, no deficits, full recovery. His case has been accepted for publication in the Journal of Neurological Anomalies. He asked about you, said he hopes you're doing all right. CM. I stared at the message for a long time. Remarkably well. That phrase hit me harder than I expected. He hadn't just survived, he'd thrived. There was no brain damage, no relapse, no lingering cardiac issue. Statistically, he should have died twice, but he didn't. 2 months later, a pair of researchers from the University of Minnesota reached out. They were compiling data on autoresuscitation, what some call Lazarus syndrome. There were fewer than 100 documented cases worldwide. Michael's was one of them. They wanted to interview me. We met in a quiet conference room. They recorded everything. I walked them through the sequence of events, the code, the confirmation of death, the return to rhythm. When I finished, one of the researchers, a neurologist named Dr. Leung, asked, "Did you feel anything unusual just before he revived? Anything sensory?" It was a strange question. "No," I said slowly. "Just stillness." He nodded thoughtfully. Many witnesses describe that. A sense that something is suspended. Not gone, suspended. The other researcher, a psychologist, added softly, "We think consciousness may persist longer than we realize. Perhaps in ways we can't detect yet." That word, yet, stuck with me. A few weeks later, Michael reached out directly. He said he'd been asked to participate in a documentary about near-death experiences. "They want the medical side," he told me over the phone. "But honestly, I want yours. You were there." I hesitated. "I'm not sure I can relive that." "Maybe you already are," he said gently. When I agreed to meet, it was more out of curiosity than closure. We met in a small coffee shop downtown. He looked healthy, stronger than before, eyes clear, posture relaxed. But there was something else in him too, something quiet and knowing. "I read the reports," he said. "They're calling it Lazarus syndrome." I nodded. "It's rare. Almost unheard of." He smiled faintly. "I think it's more common than anyone wants to admit. Maybe not physical, maybe. Something else wakes up before we do." "What did it feel like?" I asked, surprising myself. He didn't answer right away. It felt like remembering something I'd always known but had forgotten. Like realizing I wasn't alone, even when I thought I was. Then he looked at me, really looked at me. "Rachel, I saw you crying when they called it. You don't have to carry that anymore." I opened my mouth to argue, but nothing came out. Because maybe he was right, maybe I'd been carrying it all along. After that meeting, I started reading everything I could about consciousness and death. Medical journals, philosophy papers, even accounts from near-death survivors. None of it fit neatly into categories. Science defines death as the cessation of measurable function, heartbeat, brainwave, breath. But consciousness doesn't seem to care about definitions. Some neurologists theorize that during cardiac arrest, the brain experiences a burst of electrical activity, a last, brilliant surge before silence. Others think it's the body's way of softening the transition. But what haunted me wasn't theory. It was memory. Because when Michael described hovering above the bed, he'd mentioned something no one else could have known, the position of the clock on the wall. It was behind him, out of sight from the bed. He described its second-hand freezing at 4:46 before fading into blur. That was the exact time of death I had recorded. There's no scientific explanation for that. It's been over a year now. I still work at the neurology clinic. My days are predictable, my patients stable. But every once in a while, a monitor alarm will sound harmless, routine, and I'll feel that same jolt of dread, as if the universe is reminding me that I still don't understand it. I've stopped trying to explain it. Sometimes I think maybe the line between life and death isn't a wall at all. Maybe it's a doorway, and every once in a while, someone steps back through before it closes. Maybe that's what Michael did. Last month, I got a postcard. No return address, just a picture of a small coastal town in Maine. On the back, in neat handwriting, were 6 words. "Still here. Still grateful. M.A." I keep it pinned above my desk, next to a quote I copied from a neuroscience lecture years ago. "The absence of measurable activity is not always the absence of being." I used to think my job was about keeping people alive. Now I think it's about witnessing the space between. Because no matter how much science explains, there will always be that fraction of a second, that impossible heartbeat, that reminds us there's more to life than what we can measure. And for me, that single impossible moment, in a quiet hospital room on a rainy November morning, will never stop echoing.